So let's start with the different imaging modalities that we can use for GUT system. The first one is KUB, or it is also called kidneys, ureters, and urinary bladder examination. So this is just a plain radiograph from the superior pole of the kidneys down to the symphysis pubis. So in KUB, you could visualize the renal shadows. Okay, this is the right and the left side. You can also see the right psoas muscle shadow and the left psoas muscle shadow. So you have to evaluate the size of the kidneys, the location, and the renal outline. Okay? So the psoas muscle border should not be obliterated. Okay? This should be intact, because any obscuration will denote pathology. Examples will be presence of psoas muscle hematomas, abscesses, or even tumors. And then look for any radio-opacity or calcifications. So calcifications on radiographs will be white. Okay? So these calcifications could be lithiasis, whether coming from the kidneys, ureters, or urinary bladder, or even stones from the gallbladder area at the right upper quadrant. So one could also see calcifications within the blood vessels. So commonly we can see calcifications in the aorta in elderly patients. So sometimes lymph node calcifications or even tumoral calcifications. So the urinary bladder, if it's not distended, we cannot see it. But if the UB is distended, then we can see a soft tissue density here in the. So an example of an abnormal KUB. So if you compare right and left, one could see here this calcific density irregularly shaped at the right lumbar region. So it actually forms the cast of the pelvocalyceal complex on the right side here. On the lateral view, one could see these calcifications overlying the lumbar spine. So I know that this is retroperitoneally located calcification. So this stands for the Staghorn calculi. So in nephrocalcinosis, one could see several tiny mottled calcific densities within the renal parenchyma, here at the left side and at the right side. So this particular patient came in actually for a severe right lower quadrant pain, increased WBC, and increased body temp. So one could see here this faint rounded calcific density at the right lower quadrant area representing appendicolith. So why did I say it's at the right lower quadrant area? Because this calcific density is actually overlying now the iliac bone. So other findings, this one, we commonly see this, especially in elderly patients or elderly individuals. This is small rounded calcific densities with central lucencies. So these are called plebolites or calcifications within the veins. So these are just incidental findings. So another incidental finding will be the presence of an intrauterine contraceptive device in female patients. So sometimes we could see an ovoid, high density focus here in the pelvic region, egg-shaped calcific density representing stones within the urinary bladder or cystolithiasis. Sometimes, cystolithiasis will appear as this irregularly shaped, faint calcific density in the pelvic area. So another examination is what we call the excretory urogram or intravenous urography. So this particular examination, we need contrast material to be injected intravenously in order for us to visualize the renal collecting systems to the ureters and then to the urinary bladder. Nowadays, this is less popular because of the presence of CT urography. So this is an example of a normal IV urogram. There is excretion of the contrast material from the minor, major calyces, renal pelvis, ureters, down to the urinary bladder. So what are the indications for this imaging modality? So one, if you are entertaining for urolithiasis stones, which could be in the kidneys, ureters, or urinary bladder. For any benign or malignant tumors, for any inflammatory or infectious processes involving the genitourinary tract, in patients with history of trauma, and if one is entertaining for any obstruction or hydronephrosis. And sometimes you could also, another indication could also be in the presence of congenital anomalies, GUT fistula formation, and so on. So before we do IVU, we need to prepare the patient. So we'll ask the patient to have an NPO, and then we give laxatives the night before to clean the colon. And then we get the serum creatinine. This should be within the normal range. And we have to ask for any history of allergies to drug or to a particular food. So on the left side is a patient which is poorly prepared. So we can barely see the kidneys because of the presence of fecal materials here, starting from the ascending, transverse to descending colon. So it obscuring the renal shadows bilaterally. So in contrast, take a look here. This is a well-prepared patient. You could see clearly the right and the left renal shadows. The contrast material that we give in IVU is the same as the contrast agent that we also give in CT studies. So they are organic iodides, and their radioopacity will depend on its iodine content. So we have several preparations for this contrast material. So there is an ionic and a non-ionic type. We prefer the non-ionic type because it is less toxic to our patients and it has lesser hypersensitivity reaction to our patients. This is a little bit expensive than the ionic one. So the contrast is being excreted almost entirely by glomerular filtration with very little or no tubular resorption. So there are several phases of this intravenous urogram. But before we inject the contrast material, we should get the preliminary or the plain graph. And then after injecting the contrast, within 1 to 2 minutes after the injection, we get another film. So this is now the nephrogram phase. So in the nephrogram phase, one could see diffuse opacification of the contrast material in the renal parenchyma. So this is actually the best phase where you can measure the kidneys and evaluate the renal outline of the kidneys and the location. So the nephrogram phase reflects the ability of the proximal tubules to reabsorb water and concentrate the contrast material. The second phase is called parallelogram phase. It's called parallelogram phase because on this particular phase, you can now see the pelvocalyceal complex and the proximal portion of the ureter. Okay, so the contrast material has reached the collecting tubules and excretory passages. So this is the best phase for you to evaluate the fornices, if it is normal or not. Another phase is called cystogram. So this is the best phase to evaluate now the urinary bladder, because on this phase the contrast material has already reached the urinary bladder. So look for any thickening of the walls of the urinary bladder, for any abnormal filling defects of the urinary bladder. And then after the cystogram, we have the post-voiding or the post-micturition phase. So here we let the patient void for us to know presence of any residual urine, if it is significant or not. So here. And then this particular phase is taken on an upright projection in order for us to know whether there is nephroptosis or any abnormal descent of the kidney. So it is abnormal if the descent is more than one vertebral body. So on a case-to-case basis, if the urogram, IV urogram is abnormal, we take delayed images. So this is requested in patients with abnormal renal function. So it could be poorly or non-functioning. So we do delayed films in order to localize the level of obstruction. So the delayed images can be done like after an hour, 2, 4, 6, or even up to 24 to 48 hours. So it depends actually on what we see on the prior images. So I'm going to show you what a normal IVU would look like. So this is, as I have said, it's a series of images. So from the first image is the plain or the preliminary film. So this one is the preliminary film. So here, you have to evaluate for any abnormal calcifications. Okay, so this is a normal one. So and then followed by the nephrogram phase, 1 to 2 minutes after injection of contrast. One now could see calcification of the renal parenchyma. And then the parallelogram phase, you can now see excretion of contrast by both kidneys, equal excretion of contrast. Okay, here you can now see contrast material filling up the urinary bladder. Okay, this one, and sometimes one could request for an oblique projection here and this one. And lastly, the cystogram phase. Okay. So I just want to show you some abnormal IV urograms. So this one, you have 3 ureters on the left side. You trace it, and then at the distal end, they form into one distal ureter. So here one could see severe or marked hydronephrosis bilaterally and hydroureter. So sometimes one could see the drooping lily sign. So the drooping, this is a lily, it's a drooping lily sign. Drooping lily sign at the left kidney. This is because of the presence of this hydronephrotic and non-functioning upper pole moiety of the left kidney. So you just can visualize the excretion of contrast in the lower pole moiety. Okay, just like this, nephrotic upper pole and normal lower pole moiety. So these images will show you distal urethrolytiasis. So here you can see this very faint, tiny calcific density at the pelvic region. It's just medial to the ischial spine, so it's at the level of the uretrovesical junction. So this is the plain radiograph, and on subsequent images, one could see stasis of contrast at the right ureter. So this is abnormal compared to the left one. Because of the peristalsis here, you cannot see the entire ureter. Even on post-voiding or post-micturition image, one could still see the entire right ureter because of this lithiasis at the uretrovesical junction. So another examination is called retrograde pyelography. So in retrograde pyelography is being done at the operating room. So the collecting structures can be seen via cystoscope, and then put the ureteral catheter and then push the contrast material in the retrograde manner. Okay? So this is actually indicated when the IVU failed to opacify the renal collecting system and ureters. And then there is also what we call a cystography. So this is a study of the urinary bladder. A urethral catheter is inserted and then push the contrast material. So this is used if you are looking for any rupture of the urinary bladder in trauma patients or any suspected tumors, diverticula or calculi. Another examination is voiding cystography or cystourethropy. So this is commonly requested in pediatric patients, especially if one is entertaining for vesicoureteral reflux. So here we fill up the urinary bladder and then we let the patient void and then look for contrast material going to the ureter. In voiding cystourethrogram, we let actually the patient void and take images. So while the patient is voiding, we have to take the images. So here is a very nice example of a normal urethra of a male patient. So you can actually identify the different segments of the urethra. No abnormal narrowings, no abnormal filling defects. This is an example of a female urethra. It is shorter than the male urethra. Here, this is the urinary bladder, the urethra. But this is an abnormal one because you could see fistulous communication from the urethra to the rectum posteriorly. Here we could see several narrowings or strictures almost at the entire urethra of the patient. So an example of urethral strictures. An example of grade 5 vesicoureteral reflux. So you have dilated and tortuous ureters bilaterally, and you could see marked hydronephrosis of the kidneys bilaterally. So here, there is just a vesicoureteral reflux at the left side, but take note of this irregularity along the wall of the urinary bladder denoting cystitis. So the grading, so you have grade 1 to 5. So grade 1 reflux will show you the ureter with no dilatation. Grade 2, you have the reflux up to the renal pelvis with no dilatation. In grade 3, reflux up to the pelvocalyceal complex with mild dilatation. And in grade 4, you have a blunting of the fornices but preserved papillary impressions, dilated ureter. And the last grade, you have loss of the fornices and papillary impressions plus a dilated and tortuous ureter. another imaging modality that is commonly requested for the GUT system is ultrasound. One of the indications will be to look for congenital anomalies in pediatric patients. So if one is entertaining for any anomalies, congenital anomalies, their first imaging modality of choice will be sonography because there is no radiation. So ultrasound is likewise indicated in the presence of infections or inflammatory changes, in the presence of lithiasis along the GUT system, for masses, for any vascular tumors or lesions, for renal medical diseases, renal transplant, and for ultrasound guided. So by ultrasound, the kidney will look like this on the longitudinal scan, and this is the cross section. So for orientation purposes, on the left side will be the cephalad, and on the right side is the caudad aspect. So in other words, this one represents the superior pole, and this is the inferior pole. Okay, this is anterior and posterior. So the central echogenic renal sinus, or the echogenic central renal sinus, is found here. So this, if I will say echogenic, it is white. If I will say hypoechoic or anechoic, it's black in sonograms. And if it is isoechoic, it is the same echogenicity with a solid organ such as the liver or the spleen. The area here is echogenic because of the presence of fat. This is actually where the pelvocalicial complex is located. So the normal calyces actually are not visualized unless there is dilatation. And then this is the peripheral cortex with low-level echoes representing the glomeruli. And then for the pyramids here, the dark one, it is hypo or anechoic because of the presence of renal tubules, supporting tissues, and blood vessels. So the renal pyramids in children actually are more prominent as compared with that in adults. So again, see here the longitudinal slice of the kidney. So this is the right kidney. So these are the renal pyramids. It is hypo or anechoic. This is the central renal sinus, superior pole and the inferior pole. So this is the echogenic central renal sinus. So take a look here. There is hydronephrosis or dilatation of the pelvocalicial complex. That's why it's dark, and this is abnormal because as I have said earlier, the central renal sinus should be white or echogenic. So normally the renal cortex should be less echogenic, or it's darker as compared with the adjacent liver on the right side and the adjacent spleen on the left side. So this is the liver. So this is darker or less echogenic than the liver. If this renal cortex will be more echogenic or white than the liver, then one should entertain for diffuse parenchymal changes or medical renal disease. So the normal ureters cannot be seen unless dilated. The urinary bladder, if you want to evaluate for the urinary bladder, you let the patient drink a lot of fluid. Once it is distended, the urinary bladder will look like this. It is anechoic normally. There should be no intravesical echoes within the urinary bladder. The normal UB should have thin, very thin walls. If there is thickening of the walls, it will denote for cystitis. So by sonogram, we can actually compute for the pre-void volume of the urinary bladder as well as the post-void volume. So we can say whether there is a significant urinary retention or none. So the next imaging modality is CT and MRI. So what are the indications? So CT is very good if one is entertaining for masses. Okay, so one could say whether it is fluid filled or it is a solid tumor. So this is very good also for detecting the extent of the mass, the exact location of the mass, and sometimes for any displacement of the nearby organs. So for oncologic management, if you want to detect any tumor in patients with unknown primary, if you want to search for any metastasis, whether it's within the solid organs or within the retroperitoneal or pelvic lymph nodes, then CT can answer for that. Any involvement of the GUT in lymphoma, treatment planning, and follow-up. So in the presence of infections, in the presence of trauma, and if you want to detect presence of lithiasis, this is now very popular, and this is what we call a CT stonogram. The presence of renal failure, and so on. So the by CT scan, this is the cross-sectional or the eggshell slice at the level of the kidneys. So this is the right side, the right kidney, and the left kidney. You could see the elliptical or round soft tissue structures of soft tissue density with the central renal sinus. So again, because of this abundant perirenal fat, one could see clearly the outline of the kidney. So again, here is the right kidney, the liver on the right side, the spleen on the left kidney. Just above this vertebral body will be the aorta, the abdominal aorta, and slightly to the left is the IVC or the IVC, inferior vena cava. So in CT, we also start with a plain CT and also with the contrast examination. So you can easily distinguish the cortex and the medullary portions and the contrast examination. Okay, so this is plain and the contrast. So the collecting structures can also be seen well in the contrast examination. For the ureters, you look for the ureters just anterior to the psoas muscle. So, on the side of the vertebral body, on each side, at the right or on the left side, will be the psoas muscles. So look for any rounded structure just anterior or slightly lateral to the psoas muscle. So this is a normal ureter and this is a dilated right ureter. Again, the psoas muscle just anterior, there is a rounded structure representing the ureter. The urinary bladder will look like this on plain radiograph and this one on the contrast examination. Just posterior will be the rectum. If you want to look for the renal vessels, if you are looking for the arteries, then trace it from the abdominal aorta. So this is the right renal artery and the left renal artery. For the renal vein, go to the inferior vena cava. You could see the shorter right renal vein and the longer left renal vein in between the abdominal aorta and the SMA. So this is a normal GUT CT scan in different phases. So as I have said, we start with the plain without any contrast. Here in sagittal, coronal, and in axial. Okay, and then followed by the arterial phase, one could now see excretion of the contrast in the renal parenchyma. Followed by the venous phase, more contrast within the kidneys. And lastly, the delayed phase, which is used to evaluate now the collecting structures. So in CT stonogram, this is used to look for any lithiasis in the genitourinary tract system. So in CT stonogram, we take thin slices, very thin slices, from the most superior aspect of the kidneys down to the urinary bladder. So here we don't need any preparation, we don't need any contrast material. So here, down to the most inferior aspect of the urinary bladder. So any lithiasis appear as hyperdense or white. So we have here an example. A very tiny hyperdense structure here at the right middle pole calyx. Here and here. Eggshell. Okay, now this is an example of ureterolithiasis here at the mid segment of the right ureter. Coronal, it's here. And as I have said, it is just in the eggshell just anterior to the psoas muscle. You have here ureterovesical junction lithiasis. This is the urinary bladder and you could see this hyperdense structure. By coronal, it's right here, and by eggshell, it's here. Okay? And sometimes we could see congenital anomalies such as this one. The axis of the kidney is now not normal, such that the inferior pole of both kidneys are joined together by the isthmus just anterior to the vertebral body with hyperdense structures representing nephrolithiasis. So a horseshoe kidney with nephrolithiasis. So this is a coronal image. One could see two kidneys on the right side and it's fused. Another congenital anomaly, the pelvic kidney. You could see this particular kidney within the pelvic region. These are bowel loops. So for MRI, this is useful in evaluating renal masses in patients with contraindication to the IV contrast material that we used in CT scan. It is also indicated when the contrast-enhanced CT has been inadequate for diagnosis and staging of the patient. And it is also used to detect renal vascular disorders. So the appearance of the different organs of the genitourinary tract system depends on the imaging sequence. But the anatomy is also the same, such that on eggshell scan, you could see again the kidney here with the perirenal fat, which is of the high intensity signal on this particular sequence. Okay, the right and the left kidney. So here, the fat is of high signal intensity. And this one, on a different sequence, it can look like this. So the kidneys, the ascending colon, the descending colon, the right and the left psoas muscle. So on a sagittal scan, one could see the urinary bladder with the uterus superiorly. So we also used contrast material in MRI. It is called gadolinium. So upon injecting the contrast, you could see early cortical enhancement, and then it will diffusely enhance the entire parenchyma. Okay, that was my last slide. So I just would like to read this, that diagnostic imaging is a constantly evolving specialty with new technology and new imaging methods constantly arising. So keep on reading to be updated. So before I end this lecture, please let us all pray for our country and for the whole world with Pope Francis for protection from coronavirus or COVID-19. Thank you very much for your attention.